participate would be good.
Yep. No, the more people that know about this, because there are a lot of changes in CCHS, and
Yes.
And having the opportunity to explain it to people, and especially the reasons why, really helps people understand it. Because I know that people are not happy that we broke the time series for CCHS, but after running through this presentation, a lot of people, they grudgingly accept why we did it.
Mm-hmm. So you don't receive tomatoes anymore?
Yeah, no more tomatoes, no more threads.
Okay, I think Philip told you that we start at 1 sharp, so it's 2 to 1 now. I take like a couple of minutes to just briefly present the network and yourself, and then Mike is over to you.
Okay.
And I was going to say for about 45-50 minutes presentation, right?
Yeah, about that, yeah.
About that, and then Q&A for up to...
Yeah, I blocked off my whole afternoon, so I can be as faster as long as people need me to be.
Excellent. Normally, if the demand is there, we go up to 2:15 about that.
Oh, that's fine. Yeah.
And people write down their questions because it's difficult to manage such a big crowd online. So we ask them to write them down, and I read it for you. Okay. Hopefully, I'm going to be clear enough with my French accent.
That's okay. I can understand.
Okay, great. So I read it and you answer.
Sounds good.
All right. So 1 minute to go.
Okay.
Yeah, I'll let you know when I hit the start button, Sarah.
Okay. Perfect.
Right, I have one, so I will start right away.
So hello everyone, it's 1 o'clock, so we will get started. Welcome to this webinar with Andrew McKenzie, who will discuss what's new in the most recent cycle of the Canadian Community Health Survey, the CCHS. My name is Sarah Fortin. I'm the Knowledge Transfer Coordinator for the Canadian Research Data Center Network, the CRDCN. Before I introduce our speaker for today, I would like to take just a brief moment to introduce the network for those of you who may not be familiar with us. Next slide, please. The CRDCN is a partnership between Canadian universities and Statistics Canada, supported by SSHRC, CIHR, and the Canadian Foundation for Innovation. As the map shown on this slide shows, it is a truly pan-Canadian network comprising 27 research data centers, RDCs, which are located across the country. And we will soon open 3 new facilities. RDCs are secure computer labs, generally located on a university campus. They allow researchers with an approved project to use the microdata files, the confidential microdata files collected by Statistics Canada, including from the household and longitudinal surveys, census data, and an increasing number of administrative data sets. Last year, more than 1,500 researchers from various disciplines have accessed an RDC, and about a third of those were graduate students. The research carried through the network is very diverse and have helped to better understand social and economic developments affecting the whole society, as well as the factors affecting individual life course and well-being. This includes population aging, economic integration of immigrants, income inequality, labor market participation, child development, and of course, health and socio-economic determinants of health. To know more about us, I invite you to visit our website at crdcn.org, where, among other things, you can search the online bibliography, where you can find the most recent publication in your area of interest. And you can also browse the data search engine to see what data sets are currently available through the network in addition to the CCHS. So without further ado, let me introduce our speaker for today. Next slide, please. Andrew McKenzie is Section Chief in the Health, Justice and Special Service branch at Statistics Canada. He is responsible for the Canadian Community Health Survey, which began in 2000. And more recently, he also became responsible for the development of a new survey studying children's health, the Canadian Health Survey for Children and Youth, which began in 2014. Before we start, just a bit of housekeeping. Andrew will speak for about 45-50 minutes, and then we will have a question and answer period. Note that all microphones will be automatically muted during the presentation. To ask a question, I invite you to write it down by clicking on the question tab, which you can see on the right-hand side of your screen, and I will read it out loud for you after Andrew's finished with his presentation. So Andrew, thank you very much for being with us today, and the mic is now over to you.
Okay, thank you very much. So right now, we're going to check in on the slides because I don't have control of the slides myself. So we're on the title page. So today I'm going to be speaking about the CCHS redesign, and we had to make some fairly major changes to CCHS because from 2000 to 2014 it was very stable, very steady, but eventually, unfortunately, things run their course, and so there were some technical aspects in the background of CCHS that I'll get to later in the presentation that really forced our hands and made us do a major redesign. That everyone on the CCHS team has a research background of some description, and so they were firmly against making changes that would break the time series, but ultimately these decisions were made. And so by the end of this, hopefully you'll agree with me that it was necessary to break the time series, and it's not something that we want to do again for a long time. So we'll go to the next slide, please. So just a little bit of background on CCHS, just so everyone is starting from the same basis point. So it started with the Health Information Roadmap in 1999, and it really laid out the need for an ongoing health information system that would provide an indicator framework for everyone to measure universally across all the provinces and territories. And so they wanted to study behaviors, surveillance, and access to the healthcare system. And so you'll notice these three themes percolating throughout all of the CCHS and all of the questions. And this also counts for the CCHS focus content as well as the CCHS annual component. For those of you that have been playing this game a long time, that's the point ones and the point twos. So the focus content is point 2 and the annual survey is point 1. The governing committee for CCHS is a Canadian Population Health Survey Program, and this is comprised of senior management from Health Canada, the Public Health Agency of Canada, and Statistics Canada, of course. And we also have expert groups, and we form these and dissolve these on an as-needed basis depending on what topics we're working on. For example, during the redesign, we had some questions about specific topics, and so we had a variety of different subgroups or expert groups ongoing during the redesign. And then once the redesign was completed, these groups were finished. But there are some that are carrying on, for example, studying physical activity for youth, because we haven't found a satisfactory way of doing this with the level of detail that some of the stakeholders need, but also in the amount of time that's available in CCHS. The CCHS, we get hours and hours worth of requests for data every year, and unfortunately the CCHS has a firm limit in terms of the questionnaire length, so we have to balance all these priorities together. Next slide, please. So the objectives, as I said, health surveillance at the national, provincial, and sub-provincial levels. And by sub-provincial, we mean health regions. Different provinces call them different things. Health region is a StatsCan term that we've applied, but in sub-provinces, they're called district health authorities. Other areas, it's called regional health authorities. So that there tends to be, depending on the province or territory, anywhere between 5 to no more than 35 of these regions, but we can provide the exact name for each province if that helps you out. We want to be able to provide analysis on small populations and rare characteristics. So just some recent examples. There was a paper earlier this year that combined 4 years of CCHS data to study the health behaviors of indigenous populations in rural areas. And so that type of analysis is available with CCHS, especially when you combine multiple cycles together. Rare characteristics, one of the most popular uses that we've done was the study on neurological conditions to provide prevalence rates for 17 different types of very rare neurological conditions. So it's that type of flexibility that is one of the pillars for CCHS to get at these rare characteristics. Readily available data to a diversified user community in a timely fashion. So we try to make the data files as user-friendly as possible. Hopefully all the documentation, everyone reads that thoroughly, of course, and timely. I mean, it takes time to compile the data because everything that comes back from the regional offices, from the interviewers, it comes back as a flat text file. So we have to compile all of this into the SAS files and the SPSS files, and clean the data, calculate the weight. So it does take us time. So for CCHS, I know that the 2015 data are late. That's due to the redesign. But with the 2016 data and beyond, we're hoping to get back to the 6-month intervals, and I'll touch on that a little bit later in the presentation. And finally, a flexible survey instrument. And to do this, this is where we include what's called the rapid response that some people may be familiar with. A rapid response is where a cost recovery client provides additional funding to cover extra time in the CCHS. So we line these up with the collection periods of CCHS. Every 3 months, we start a new collection period, so we can have a rapid response for either 3 or 6 months in the CCHS. And then after that, we try to provide data to them within 3 to 4 months. So it is a quick and relatively cost-effective way to get data on a specific topic, as long as it fits well in CCHS. It is expensive, but collecting data from tens of thousands of people is never going to be cheap. And if people have further questions about that, we can continue that discussion offline. Next slide, please. So the redesign. So there were 5 key objectives for the CCHS redesign that were developed in late 2011, early 2012. And this drove a lot of the changes that followed the CCHS redesign. And the objectives were developed in partnership with the stakeholders I mentioned earlier, the Public Health Agency of Canada and Health Canada, as well as consultations with other federal departments, provincial and territorial ministries of health, and other ministries that are somewhat or users of CCHS data, and even right down to the ministries and regional health authorities. We went to conferences. So we really tried to consult as much as possible on the redesign objectives. And if anyone is interested, we are starting the next redesign in April 2016. So if you'd like to feed into the objectives for the next redesign, then please don't hesitate to contact me. So the 5 objectives. So first, we wanted to study the feasibility of adding children less than 12. For as long as I've been around health data, there's been a real gap for data on children less than 12. We used to have the National Population Health Survey, but that stopped being cross-sectional in 1998. CCHS was designed in the late 90s, so at the time, there wasn't a lot of urgency for data on kids less than 12. Fast forward to 2012, and suddenly all the data are 14 years old, and there's a serious need. So we evaluated the feasibility of adding kids less than 12, and I'll talk about that a little bit later. We needed to review the content and create a long-term content plan for 2015 through 2022. Some of the content that was in CCHS was getting stale. It had been around since the late 1990s, and it needed to be refreshed, and so I'll talk about that as well. We needed to transition to something called the household survey frame. The CCHS, it used to use 2 different frames. One was an area frame, a list of households in a given area, and then the other one was a list of telephone numbers, because we couldn't generate the area frame fast enough in the volume that CCHS needed. And then we would basically just sort of mash these 2 frames together. The problem was it resulted in a really high design effect, which made CCHS very inefficient in terms of the sampling. So we needed to transition to the household survey frame, and I'll explain that later. We also needed to revisit the sample allocation strategy. The health regions are determined by the provinces, and so we try to respect them and support them as much as possible. But when we designed the CCHS, we had to lock down the boundaries. And between the late 90s and say 2013-14, when we started pinning down the methodology, the number of health regions had changed from 141 down to 107. So we had a lot of changes, a lot of odd results because of uneven distributions of samples in provinces. So we wanted to correct that as well as future-proof it, because we didn't realize the extent and the frequency that provinces would be changing the boundaries of their health regions. And then finally, we wanted to add an internet collection option. So that was the plan for 2015, but unfortunately that's been postponed until 2021. The infrastructure to support that at Statistics Canada just it isn't ready yet. Next slide, please. Okay, so a little more detail on adding children less than 12. So we completed the feasibility study in the summer of 2013. The two sort of competing options that bubbled to the surface, number one was just adding a second interview to any households that were receiving the CCHS, because right now we randomly select someone 12 plus and we interview them. So the other option that was evaluated was if we land in a household that has a child 0 to 11, then we add a second interview with content specific for that child 0 to 11 and interview them. The major problem with that approach was the rarity of children 0 to 11 in Canadian households. Only about 20% of Canadian households have a child in that age range. So it wasn't going to be able to support the level of detail that was required by the stakeholders involved in the CCHS program. So we really had to look at a second option. And so that was a completely standalone survey using the Canadian Child Tax Benefit as a frame. This frame has outstanding coverage, 96% or higher in the provinces, 94% or higher in the territories. It's just not possible to find a better frame than that. So we were able to collect data, or we will be able to collect data in the volumes that we need using a very efficient design because we have such a good frame, and it'll meet all the data needs of our stakeholders. And we can accept sample buy-ins or top-ups, and it's a very flexible design that we're able to do. We're not limited by the number of households that have children that we happen to stumble onto with CCHS. So the collection strategy, it will be internet data collection. We're going to send a letter out to the address of the person registered to receive the Canadian Child Tax Benefit. We'll give them a fixed window to respond. We haven't pinned that down exactly for the full production cycles, probably somewhere in the area of 3-4 weeks. Any non-response will be followed up by a telephone interviewer. It'll be a stratified, simple, random sample design, so there's no clustering, which means that it'll be a very low sample, design effect. The clusters tend to have really increased the design effect, and also merging multiple frames the way CCHS did also causes a higher design effect. So you should be able to do much more detailed analysis with we call it CHESY, the Canadian Health Survey on Children and Youth. So it'll just be a very efficient design. The pilot test was in October 2016. Production is to be determined pending funding. My best estimate is fall 2018 for this collection to start. It'll run through June 2019 with the data file in very early 2020, but that is all pending final funding confirmation. Next slide, please. So for CCHS, we also had to review the content and come up with a new long-term content plan. So during the redesign, 54 out of 98 CCHS modules were modified, and all the variable names are new. Most of the changes are minor. Some modules are new or significantly modified. The ones to pay attention to that are most popular are physical activity. So there is a new module called PAA, that's physical activity for adults. There's also PAY, physical activity for youth. Those are both completely brand new. Those of you that are experts in that area will see that we drew inspiration from CPAC and some of the other existing common modules for physical activity. Sedentary activity is also a new module. In fact, for 2017, we also came up with another new sedentary activity module because the one for 2015 and 16 was not performing as expected. Fruit and vegetable consumption was completely redesigned to line up with the food guide, as well as patient experiences to try and gauge the access, the quality of care received by Canadians using the healthcare system. Territories now have 2-year themes only, so you can only get annual data for provinces. So what happened with the territories was traveling in the territories is incredibly expensive. And so what we're doing is we're still visiting the same number of communities in the territories, but instead of visiting those communities every single year, we're visiting them over a 2-year basis. So each time we visit one community, we're doubling the sample size. We're basically visiting them and collecting 2 years worth of sample. But since we're only visiting all of the communities over a 2-year basis, then the estimates for territories are only available on a 2-year basis on the 2-year files. We had a final content plan by October 2014, and I can send that out by email if people would like an electronic copy of that. And the rapid response option is always available to meet further needs. But I do encourage people, book early and contact me as soon as possible, because right now we're already booked about a little over 50% between now and 2023. So it is extremely popular and books up very early. The next available time slot we have available is January 2019. I know that's not very rapid, but it is popular. Next slide, please. Okay, so the household survey frame. This is really what forced the hand to break the time series. We had to change some content. We didn't want to be the survey that's still asking about typewriters and VCRs. That things do evolve, so we had to update the content. But this slide really is what forced our hand and forced the decision to break the time series in CCHS. Previously, CCHS used a dual frame design. So there was an area frame. It was produced by the Labor Force Survey. And so this was a list of all dwellings in a given area. And it comprised 40% of the CCHS sample right from the beginning. But unfortunately, Stats Canada just didn't have the infrastructure to produce this in the volumes needed for CCHS. So we had to make up the balance with a telephone frame, which is never ideal. And as time went by, it got even less ideal because cell phone-only households were not included, and the quality was decaying. And by the time we were doing the redesign and we started studying this in 2012, 2013, cell phone-only households represented about 50% of households in the largest urban areas. So in Montreal, Toronto, Vancouver, we were missing 50% of all households because they were cell phone only and they were not in the frame that we were using. And we didn't want to adapt it over time because that would also impact the comparability. So the household survey frame is a major improvement for a number of reasons. Number one, it is a complete listing of every household in the entire country. In fact, it is so good that sometimes we're running into situations where it's identifying structures that look like they could possibly inhabit it, but it turns out it's a large garden shed or something, a pool shed or something like that, and it looks like it could be some kind of a guest quarters or a bunkie or whatever you want to call them in the cottage countries. But it's a good problem to have. We are definitely not missing anybody. This is a comprehensive survey frame. It's continuously updated with the various survey administrative data. So we get records from telephone companies, cell phone companies, building permits, demolition permits, tax files, all kinds of things. And the census feeds into it. So we're already using the most up-to-date telephone numbers and addresses provided by the 2016 census. So it is an outstanding frame. And the thing that I really like about it is as long as people continue to live in households, and it doesn't matter if it's a house or condos or apartments, as long as they're living somewhere in Canada, then the household survey frame will never have to be replaced as the major frame for CCHS. And it is just one frame, so it's a much more efficient design as well. So you'll see in the technical documentation coming out March 22nd that the design effects are significantly lower for every province and territory and every age group. So it is a major improvement that you're going to be able to do much more detailed analysis with the CCHS sample size, and we maintain the same sample size. So the raw sample every year is 108,000. I know response rates have been declining, and we're doing our best to improve on that. But the take-home point is we will not have to change the frame again. This household survey frame, I don't want to call it perfectly future-proof. People may start living on the moon or something, but until something really dramatic like that happens, we'll never have to change the CCHS frame again. Next slide, please. Okay, the important point to note, though, is CCHS cases for 12 to 17. The rarity of 12 to 17 caused a heavy selection bias, which increased design effects. When we were rostering the household, when the interviewer first makes contact, we're getting a list of all people that live in that household, so we can randomly pick someone. To make sure that we got enough 12 to 17 in the household, we had a very heavy selection weight on them because they're so rare. So if you landed on a household that had one 12 to 17 and one 65 plus person, the odds were over 90% that we're picking that 12 to 17-year-old, even though it's supposed to be random. But odds over 90% are not very random, which had a big impact on the design effects. So now we use the CCTV to sample the 12 to 17. And since there is no overlap with the CCHS sample coming from the household survey frame, there is no effect on the design effect. So there are 2 frames, but they're completely exclusive. It doesn't cause any technical problems. So the age groups now are 12 to 17, 18 to 34, 35 to 54, 55 to 64, and 65 plus. We seriously considered putting a 65 to 74 and a 75 plus in there, but the weighting on the selection probabilities was going to cause some technical problems, and the amount of difference was marginal anyway. So that the 65 plus gives you almost the same sample distribution, and it was not worth the price that we would have paid on the design effect. So those are the 5 age groups, and so in your analysis, I do encourage you to use these 5 age breakdowns. You will get the most powerful analysis and the most bang for your buck on your analysis. So the adjustments, so similar adjustments to area frame in terms of non-response, corrections, out of scope, calibration, all those kinds of adjustments. It's all very similar to what we call the area frame or the household survey frame that I mentioned earlier. The key point, though, is we're not producing household weights for the 12 to 17 cases, because all the cases that come out of the household survey frame, so that are intended for 18 plus, all those households are fully representative of the Canadian population minus the standard exclusions. So these are the extremely rural, remote areas, First Nations and Crown lands, military areas, and institutions. So outside of that, the households selected by intended for the 18 plus population are fully representative. So we don't need household weights for the 12 to 17, and that would cause problems. So that's why we exclude the 12 to 17 cases from the household weights. Next slide, please. We should be on 12, as long as we're aligned that properly. Okay, so we also had to revisit the sample allocation. So as I mentioned, the CCHS originally had 141 health regions. It was a very simple design. We allocated 500 units per health region, but provinces have reduced their number of HRs to 110, and even since this slide was made up, it's down to 107. So this resulted in some really odd distributions of samples in some HRs. Areas where you think you should be able to do some really detailed analysis, you weren't able to do that much detail because they've had just explosive growth in that area since the late 1990s. Other areas that are sort of boundary to a CMA or something that you wouldn't expect to have a lot of sample. There was a lot of sample because it was a sliver between old and new boundaries, and so there were a lot of weird things going on. So the redesigned CCHS sample allocation, it responds to HR boundary changes by the provinces, and I'll explain that on the next slide. It provides similar quality estimates for all HRs within one province. So the key thing here is you will notice that there's different quality between HRs of different provinces, because if you take Saskatchewan and Manitoba as an example, they have a similar population, but Saskatchewan has more than roughly double, if not exactly double, the number of HRs. They want to stratify their province much more finely than Manitoba has. So when we allocate sample at the provincial level, they get less sample for each HR. And so that is one of the effects in this, but at the same time, you can always group the HRs if you do want to boost up the quality of your estimates. And it significantly improved the design efficiency to reduce the design effect by doing it in this fashion. Okay, so here's the more technical nuts and bolts for those of you that are interested. So step 1 is a power allocation proportional to province size. So basically, we take the total sample, the 108,000 CCHS cases that we're going to select for the year. And of course, this is a larger number because we're correcting for non-response. And we divide that by the province size, but there is a power allocation to make sure that not all of it ends up in Ontario, Quebec, and Alberta, and BC. We want some going into the smaller areas like PEI and New Brunswick, Nova Scotia, et cetera. So that's what the power allocation does, is it divides the sample. It uses the population size as a guide, but not entirely. It does make sure that there is, it does force some sample out into the smaller population areas. And then step 2 is another power allocation proportional to the health region size within that province. And so we ensure a minimum prevalence of 10% in each HR, or 15% in the smallest HRs. And then next, we have to apply a maximum sampling fraction of 1 in 20. That is a Stats Canada requirement, non-negotiable even for me. And this is to make sure that we don't visit the same dwelling more than once every 5 years with CCHS, because even especially in Nunavut, we end up banging on the same doors for the same or different surveys more than once every 5 years. CCHS is not allowed to visit the same household more than once every 5 years, but other surveys like LFS and GSS and the other regular sort of big ongoing surveys, they might visit that dwelling within that 5-year window. So we try not to irritate people too much. We know not everybody's really excited for us to come to the door. So that's what this sampling fraction is all about. In 4 HRs, this increases the minimum prevalence to 25%. It's not ideal, but it is what it is. This is what we have to do. Next slide, please. Okay, internet collection. So we had to delay internet collection till 2021, and so what we did is the next redesign for CCHS was supposed to be launching in 2023, so we pulled that ahead. We didn't want to launch internet collection sort of in the middle of a design and then do a redesign in 2023. So everything is going to happen in 2021, and I know it may seem odd that I mentioned we're starting the next redesign in April, even though we're only disseminating the data from the last redesign in March. So this run of CCHS will only be 6 years. But the good news is I don't foresee any major technical changes required. As I said, the household survey frame has more or less future-proofed CCHS. The sample allocation has future-proofed CCHS. The only thing that could change is for the content. If we have to make changes to content to make it work on the internet, that will break the time series for that question. And I know there are questions of mode effects, so we are planning a mode effect study. In terms of the exact collection strategy, we're still working on that. That's going to be one of the priorities for the redesign. But we're doing ongoing testing to figure out the best way to roster a household and randomly select someone to participate in CCHS. Okay, next slide, please. We should be on 15. So for the current design of CCHS, we also redesigned the collection strategy. Since the territories are only representative over 2 years, we also use this opportunity to make a number of other changes. So cell phone numbers, they are used to contact households. Historically, that wasn't allowed at Stats Canada. Even if we did accidentally turn up a cell phone number from tax files or something, we were not allowed to use that cell phone number. But now we are. So the telephone, CADI-CAPI, sorry, those are acronyms. But so CADI is a telephone interview, CAPI is a personal interview. So the proportion is also different. So you need to keep an eye on that as well. So the way that CCHS collection works now is if we can locate a telephone number, regardless if it's a landline or a cell phone, if we can find a phone number for that household, we're calling them with a telephone interviewer. If we cannot find a phone number for that household, then we flip it over to a personal interviewer and they actually go bang on the door. After 4 weeks, if all the cases that we turn up as not in service or it's a bad match for that address, because we select the household, we don't select the number anymore, we're selecting that household. So if we can't find a good phone number for that household, that case gets flipped out to a personal interviewer as well, and they'll drive over and bang on the door. After 8 weeks, health regions that have a response rate below 60%, we transfer as many cases as can be handled by the field interviewers in the final 4 weeks of collection. I'd love to say we transfer all cases out to the field interviewers, but unfortunately we can't. So this is a bit of a negotiation to see what they're able to handle during the final collection push for CCHS. And so that's what the CADI-CAPI transfers are. So it's a responsive collection design, trying to boost response rates as much as possible. And I should note that the child tax benefit cases are only done by telephone interview. They're not clustered, so they really could be anywhere within Canada. And so we don't want field interviewers driving all over the place. Next slide, please, on 16. Okay, so using redesigned CCHS data. So the first release of redesigned CCHS data is going to be March 22nd, 2017. We had to delay it because we ran into some technical issues rebuilding our systems to handle the new redesigned data. But we are on schedule now, and it will be released March 22nd. So it'll be released to the RDCs that day, and so it should turn up in the RDCs within a few days after that. I'm not sure how long it takes them to stage it these days. Okay, so the 2016 and 2015-16 combined 2-year files, they'll be released in late September 2017. If we're not done working on the 2015 data until March, that takes us 6 months now that we've got all our systems in place. So 6 months is September. The 2017 data and beyond, they will be released in June. And for the next redesign, we are planning to to try to get the data out much more quickly than 15 months after the redesign. But we'll see how that goes as we get closer. And I should mention, I'll remind people that the annual data is provincial only, regional and territories data in the 2-year file only. Next slide, please. So using the redesigned CCHS data. So we do not recommend comparisons for the 2015 data and beyond with 2001 to 2014. As I mentioned throughout the presentation, we're using a new frame, a new sample allocation, a new weighting and estimation strategy. And I didn't get into that because it is quite technical. There will be some explanation in the technical information coming out with the user or with the documentation in March. But if you have questions, then they can contact us about that. We also revised the content and have a new collection strategy. So with so many changes, what do estimation differences mean? Can you really be confident that if you say there's a change or there's not a change, can you be confident that there actually is a change in the population and it's not due to all the changes we made to the survey? So there will be documentation explaining all the changes available with the March release. So I just want to point out that even content that has not changed, it is subject to the many survey design changes in the background, so it's not necessarily comparable. So changes, no changes between years, don't necessarily reflect population changes. Next slide. So we're on slide 19. So this is just a slide about the available documentation that will be coming with the release. So there will be a document on giving an overview of changes that we made during the redesign. There will be a revised user guide. And so this is how to use the CCHS data, and there's a lot of important information in there, so please read it carefully. There will be the usual CCHS release materials that you're accustomed to getting, so the data dictionary, the derived variable guide, layouts, questionnaires, those kinds of things. There are some new CANSIM tables and fact sheets that I'll talk about in a moment. We will not be providing a variable concordance table because, as I said, we do not recommend making changes or comparisons between the 2014 and 2015 data. Next slide, please. So fact sheets. So we have one new fact sheet, and we've discontinued a few that weren't very popular. So the fact sheets that we're going to have in March, there will be diabetes, body mass index, physical activity, primary care provider, chronic conditions. And so this fact sheet will be a summary of asthma, arthritis, and the more popular chronic conditions. There will be a fact sheet on smoking, drinking, fruit and vegetable consumption, life satisfaction, and a new one on the health behavior score. And this is a new score that the CCHS team has developed, and I've got a slide about that next. We have discontinued the fact sheets on exposure to secondhand smoke, self-perceived health, and perceived life stress, because according to our website, no one was reading them anyway. Next slide, please. Okay, so the health behavior score. There is a typo. It's a summary of 4 indicators, not 6. Originally, we were looking at 6. That's why it says 6, but we found some issues, so it's down to 4. So it's going to be a summary of smoking, fruit and vegetable consumption, heavy drinking, and physical activity. And we're doing the analysis by age, sex, income, education, and province. And so you'll be able to check that out on our website March 22nd. Next slide, please. So the data tables. So you're probably familiar with calling them CANSIM tables. You're going to see a new acronym popping up. Because we're going to be one of the first social surveys to use a new system. It's called the CODR. It's a Canadian Output Data Repository. So if you see CODR, it's synonymous with CANSIM. It's just newer, better, more powerful. You'll like it better. I can't think of a single advantage of CANSIM over CODR because it was designed in the 70s, I believe. So there will be 2 CODR tables. The first will be on health characteristics broken down by age, sex, and the 10 provinces with 26 indicators. And these 26 indicators were developed in negotiation with Public Health Agency and Health Canada, and they are the most popular indicators from the previous CANSIM tables. And then the second table, again, will be health characteristics, this time broken down by household income quintiles and educational attainment in the 10 provinces. And the territories will not be on here because this is a 1-year table. They will be available on the 2-year tables that will be coming out in September, and again with 26 indicators. Next slide, please. Okay, so the indicators on the CODR tables, as I said, they're in consultation. We came up with 26 core content indicators. Most of them are the same as previous years. So the new ones, access to primary healthcare provider, physically active for 18 plus and 12 to 17. We modified the BMI for youth indicator, so we're now using the WHO standard rather than the COL standard. and removed from the table, but still available on the data file, except for the participation activity limitation, the RAC. So we have pain and discomfort, exposure to secondhand smoke, the combined BMI variable, flu shot, bike helmet use, functional health, and injuries. So all those variables are still in the data file. They're just not going to be on the CANSOM table or CRDR table. Next slide, please. So these are the contacts. I went through a little quicker than I planned on. So the CCHS content manager is Linda Lefebvre. The dissemination manager is Sean Brulé. The collection manager is TD Nguyen. The project manager is Amanda Wright. And for the kids survey I mentioned earlier, this is the Canadian Health Survey on Children and Youth. The content manager, and now Lisa is also now the project manager. That's Lisa Verdun, and I'm the chief responsible for both these projects. So all of our contact information is available on the website. So that's the end of the presentation, so we can open it up for questions.
Yes, excellent. Thank you very much, Andrew. I have a few questions already. Some individual participants did write down a number of questions, so I can start right now with, I'm sorry, I hope I will pronounce the name correctly, Nosaba Degani. She's asking about Ontario is adding subregions within regions. Would this require a further change for Ontario?
I know that Ontario has the LINs. Hopefully this is the region that they're talking about. This did come up during the consultations, and so the new sample allocation strategy did take the LINs into account. Historically, Ontario was buying additional sample in the CCHS to account for their LINs, but this was quite expensive for them, and so during the redesign they asked us to come up with a design that would support the LINs and the health regions, so that the LIN variable will be available on the CCHS data file.
Okay. And she goes on saying, I think Andrew just said that regional data will be only available in the 2 years files. Is that correct? If so, if that is, we can only have regional data starting September this year and for 2015-16 2-year cycle?
No, the health region will be available on the 1-year file. But the variable will only be put on the 2-year CANSOM table files, because when we produce the CANSOM tables with health region on it, the tables are mostly blank. Sorry, with a 1-year file. The CANSOM tables are mostly blank for the health regions, but that variable will be available on the annual file. So you'll have some regional analysis available, but only with half the sample you would have with a 2-year file that's coming out in September.
Okay, thank you. Someone else, Anita is asking, sorry, I missed what percentage sampling for HR, I guess that's health regions, in the redesign, I believe that was in connection with the presentation, how you redesigned the survey, and she was wondering about the percentage for sampling for health regions. Is that clear enough?
I don't understand the question. I'm not sure what they mean by a percent. In terms of sampling fractions, we're just less than 0.2% of the entire Canadian population. But in terms of percentage of the provincial population that goes to HR, it changes. They're all different because it's allocated by the population size of the province and inside that HR. So every province and every HR will probably have a different percentage of the sample.
Okay, thank you. Lisa Corson asking, we were told that the CCHS is becoming mandatory in 2017-18 to mitigate decreasing response rates. Is this still planned?
The CCHS was supposed to become mandatory in January 2017, but 2 things happened. First, we had a new chief statistician sworn in. Anil Arora has replaced Wayne Smith. In June, Wayne Smith authorized CCHS to become mandatory starting in January 2017, so right now. And Anil Arora came in. He wanted to study this in more detail. And also, the Statistics Act has been reopened by Parliament to have another look at it. And so the decision to make CCHS mandatory was postponed. I still think it's going to happen for 2018 to start, but I'm not 100% certain. It hasn't been signed off yet by the new chief statistician. So that's to be determined.
Thank you. Several persons are asking about a copy of the slides. Yes, slides will be available afterwards, as well as the video recording. So all this information will be sent to you after the webinar. All right, next question. This is Megan McKenzie. Are there any plans for another CCHS mental health survey in the next few years? The 2012 survey dropped many variables from the earlier version, and it would be nice to see a new data set.
I'm not responsible for that's the CCHS Focus project. I'm responsible for the CCHS Annual. I can tell you that I work closely with the CCHS Focus team. They are in the middle of completely and totally redesigning the entire CCHS Focus approach. They're trying to move towards more frequent, more flexible survey designs. Instead of doing it one topic, such as mental health, once every 9 years with a massive sample and going into excruciating detail, they're looking at doing more frequent topics in a more flexible approach and with more innovative designs. But what exactly that means, they're still pinning that down. There's ongoing discussions. In fact, this morning they were meeting with Public Health and Health Canada to discuss exactly how they want to operationalize this. But all I can say is they do recognize that this data is not getting out frequently enough, and so they are looking at options for doing this more quickly. But what it'll ultimately look like, I'm not sure yet.
Excellent, thank you. Next question by Jennifer Black. She asks, CCHS 2.2 2004 was the last time detailed dietary data was collected. You mentioned the concerns about comparing 2015 with earlier cycles. What does this mean for our ability to reasonably compare dietary change reported in 2015 in the nutrition survey to 2014 findings?
There's three different things going on there. First, the 2.2 is another CCHS Focus project, so that's not something that I've ever worked on or been responsible for. But there was a 2015 CCHS nutrition survey, and that data is in the middle of being processed right now. And if I'm not mistaken, it's going to be released in June. I'm not 100% certain, but I believe that's what it is. If you shoot me an email with your contact info, I can contact the CCHS nutrition team and get the exact release date. So that's one part of it. The other part is that the 2015 CCHS was never designed to be comparable to the 2004 CCHS nutrition survey. That entire survey, including the nutrition consumption log or whatever it was called, I think they called it a food diary, they are completely and totally different approaches to measuring nutrition. Some of the same people were involved, especially the Office for Nutrition Policy and Promotion at Health Canada. They were some of the key designers for some of the questions, especially on the nutrition survey. But they were not designed to be comparable. And the third thing is the 2004 CCHS used a very different sampling design from even the regular CCHS or the redesigned CCHS. So right there, that's another reason why you have to make your comparisons extremely carefully.
Thank you. I have a question from Maureen Anderson, and she's asking, will there still be a pump and share file? I think the answer to that is yes, but do you want to confirm?
For the CCHS, yes, there will be master files, share files. So that for the 2015 data, on March 22nd, we'll release the master file to the RDC program. We'll release the share file to Public Health Agency of Canada, Health Canada, and all the provincial territorial ministries of health and the ISQ in Quebec. The public use file, the pump, that for 2015, the way that we do the pumps is we always do a 2-year pump. So there'll be a 2015-16 pump, and then we do the second year, so a 2016 pump. So that will be coming out way, not for a while, that's way down the road. Guessing probably somewhere in the summer of 2018, fall 2018, somewhere in there. But we'll have to see. We haven't even started working on it, to be honest. So it is definitely way down the road.
Thank you. Another question from Elena Jensen. I believe community data collection in the Northwest Territories only conducted by going door to door, other than yellow knife. Has this changed with the availability of cell phone use, or will the door-to-door collection still continue?
Sorry, could you repeat that again? You kept breaking in and out. I couldn't understand the question.
I can read that one well the question. So it's the question was, I believe community data collection in the Northwestern Territories was only conducted by going door to door, other than Yellowknife. Has this changed with the availability of cell phone use, or will door-to-door collection only still continue?
CCHS in the capitals, so Yellowknife, Whitehorse, and Iqaluit, they have done telephone interviews. Outside of the capitals, it's not door-to-door by choice. It's door-to-door because we can't find a phone number. If we can find a phone number for the dwelling, we will call them. The only time that we'll go bang on the door is if we cannot locate a telephone number. So in the territories, 90% of the dwellings we can't locate an accurate telephone number for a variety of reasons. Usually it's because they're living where they're living, they use a post office box and they don't have a civic address. And so when we get a list of all the dwellings in the area, we don't have the civic addresses to match with the post office box, and so we can't look into tax files or cell phone records or anything like that to pull out a phone number. With the 2016 census, we did ask for both their civic address as well as their mailing address. So we're hoping to improve some of the linkages, but I haven't been able to study that yet. The availability of the 2016 census phone numbers and address information is too new.
So, do you hear me well now?
You're still breaking up a bit, so I'll read the questions again. So Eugenia Kwan asks, I have noticed that variables related to dietary patterns, like fruit and vegetable consumption, was only collected from certain provinces in CCHS 2014. From what I remember, certain variables were not available for Ontario. Would CCHS 2015 include all provinces for fruit vegetable consumption for public data?
I'm just going to pull out the content plan because the provinces are allowed to pick 10 minutes of optional content per year, and so that's why in some years you'll see inconsistent coverage of variables. I'd have to look that up. If I recall correctly, fruit and vegetable consumption, I think, was core content for 2013-14. So it should have been asked for everyone. The only one that it may not have been is the Ontario oversample, but I'm 99% sure it would be asked for them as well. And for 2015-16, fruit and vegetable consumption was core content as well. So it should be there. If it's not there for all cases, then please try and get in touch with us. Don't send me the cases by email, but please try and get in touch with me so we can investigate that further.
Okay, so Maureen Anderson had a follow-up question. She was asking, how do you recommend regions comparing trends over time for these indicators, given the 2015 and onward will be a clean slate? Is there anything we can do to utilize the 2014 data?
I mean, I'm not going to tell people that it's a good idea to do this. I know people are going to do this. The key thing I'm going to say is do it very, very carefully, and draw your conclusions very carefully, considering all the changes that were made. You can't make correction factors. The changes that we made, you can't design a correction factor or adjustments or anything like that. It is a change, and so you need to just be aware that there are changes in there, and be careful if you see a difference between 2014-15 and you want to write papers or something.
Okay. Matthew Neer asks, can you please provide more details on the new indicator for access to a primary healthcare provider?
I can send the module out if they'd like to take a look at it, but I don't have it in front of me to read off all the questions. So if they want to send me an email, I'll send you a module. I'll send them all the questions that were asked.
Perfect. Sorry. Next question from Noshaba Degani. Kai has been working with experts across Canada to set common equity stratifications, including for age. I am not sure that the groups you have set here are the same as what they will be proposing. Is there any flexibility to adjust the age groupings?
No.
That's a short answer. So, Elena Jensen, I think that's the last one we have. Do you have translators for households where no one speaks English or French?
In the regional offices, they keep a list of people that have been approved to speak non-official languages. And so if they do encounter a household where they speak Russian or Spanish or one of the non-official languages, they'll have an interviewer that speaks that language, call them and make contact, and they'll translate the CCHS on the fly. For the older version of CCHS, some of the key questions and the introductory texts were translated into 10 different languages. We haven't done that yet with the redesign. We haven't had a chance, but it is on the to-do list.
Okay, perfect. So I don't know, Sarah, if you maybe you want to jump in. At this point, we don't have any more questions. So.
Well, actually, Philip, I think there's another one from Matthew here.
Oh, yeah, just had it. Well, actually, two new ones. Okay, so I'll read in. So Matthew Munir, again, has there been any additions to the list of chronic conditions that survey respondents are asked about?
During the redesign?
Yeah, that's.
Okay. Oh, yeah, I guess
yes.
it wouldn't
Yes.
say. I'd have to take a look. It's been a while since I looked at the list and compared it between 2014 and 15. But if they want to contact me, then I can send them the old and the new version, and they can see what the differences are, or we can summarize them.
Perfect. Another question from Liz Corson. It's a follow-up question about the CCHS becoming mandatory. If it does happen that it becomes mandatory, will that influence the comparisons before and after the change?
We're going to take a look at it, but it definitely is a concern. When we did the pilot test of a mandatory CCHS in January 2016 to March 2016, we noticed a 15.5% percentage point increase in the response rate from 62 and change to 77 and change. So when you're adding that much of more of a response, and the people that we were getting tended to be a more difficult population to reach. For example, we were getting more immigrants and more non-official language speakers and more indigenous populations, more youth. So when you're bringing in more of a unique groups, then the chances are you're going to change your estimates. And even comparing the characteristics of people that we were getting with the old CCHS versus the mandatory CCHS, we are seeing differences. And a lot of them are related to health behaviors. So the people we were getting with the mandatory survey, they were more likely to be smokers, heavy drinkers, overweight or obese, minimal exercise, poor nutrition. So not all of these differences were significant, but the sample size of the mandatory test was also very small. It was only 5,000 households. So we are going to evaluate the comparability, but it is a concern. It is one of the things that keeps me up at night.
Perfect. So that was the last question. So I guess, Sarah, maybe you can conclude this webinar.
Yes, I'm sorry. Do you hear me now?
Yep.
I'm having difficulties, I guess, with my computer. So it's 2 o'clock, and I guess we've read all the questions. Thank you very much, Andrew, for this presentation, and thank you everyone for joining us today. As I said earlier, the PowerPoint and the video recording of the webinar will be available shortly on our website and on our YouTube channel. So feel free to share it with your colleagues. And note that there will be a French presentation about the CCHS redesign on next week, actually, on Wednesday as well. So if you wish to invite our colleagues that speak French to join us, do so, please. So that's it for me. Again, thank you, Andrew, and see you soon.
Welcome. Thank you.
Thank you.